So for those of you who don't know Brandon Foreman, Brandon and I did our training together as co-fellows, and I am so proud to call him a friend and colleague. The title of his presentation is Multimodal Monitoring and Precision Medicine in Neurocritical Care. He's an associate professor of neurology and rehab medicine and neurosurgery at the University of Cincinnati, serves as the associate director for neurocritical care research with the Division of Neurocritical Care. He's trained in both clinical neurophysiology, critical care, EEG, and neurocritical care at Columbia, and also holds a master's in clinical and translational research with a certificate in biomedical informatics from the University of Cincinnati. He's a member of the multi-center collaborative efforts, for instance, the Critical Care EEG Monitoring Research Consortium and the Cooperative Spreading Brain Injury Depolarizations Consortium, or COSPID. And he is very, very well funded. He has NIH funding, amongst others, and has published a lot on this topic. So Brandon, please take it away. Thank you again for joining us.
Yeah, absolutely. Thank you for the kind introduction, and thank you guys again for your patience. I've got a lot to go through, so we'll just dive in and get through what we can by the end of the hour, and hopefully we'll be able to get through everything. Here's my disclosures. Nothing is super relevant for this. We're going to be focusing on sort of the practicalities and clinical rationale for multimodality neuromonitoring as really a source for precision care and precision targets in neurotrauma specifically, and in neurocritical care generally. We'll talk a little bit about the challenges of doing multimodality neuromonitoring in the research setting, and then how do you integrate some of these things in research directions for the future. So in terms of the rationale for multimodality monitoring, the concept of multimodal or multimodality monitoring in general is not specific to the brain. Really, the idea is putting multiple sources of information together in an integrated way and interpreting them such that you get more complete information about whatever organ system or thing that you're trying to look at. When it comes to multimodality neuromonitoring, the stuff that we often deal with, it's really aimed at the prevention or detection and management of secondary brain injury, which is sort of a central tenet of neurocritical care in general. And we do so in kind of, in kind of this simplified fashion that I've got here. This is kind of the way I think about multimodality monitoring when we're doing this in the neurotrauma space, for instance, in terms of the mechanics, the pressure and flow within the skull into the brain, the supply of energy substrates, so metabolism, and then ultimately function. How is that brain functioning? And, in an awake, normal human being, you can do a neurological exam and gain a lot of information about functioning, assuming that the mechanisms, or the mechanics and the metabolism are relatively normal, or at least sufficient to allow you to have some clinical kind of understanding of how that brain is functioning. But in someone with a limited exam, someone who's comatose, someone who's experienced severe traumatic brain injury or subarachnoid hemorrhage, for instance, we're often left trying to intuit function from other sources. And so an extension of our exam, such as EEG, becomes helpful. When we talk about patients with neurocritical care and patients with traumatic brain injury specifically, secondary brain injuries end up being a very important part of what we're looking for, what we're trying to manage. These sorts of things are really critical. They occur frequently in 1 out of every 4 patients with neurocritical care needs in general, whether it's stroke or trauma. Secondary brain injury or the clinical manifestation of that neurodeterioration occurs. And that is sufficient to increase mortality in things like brain trauma from 10% to 50%. So it's really, really important to detect secondary brain injury. But secondary brain injury comes in a lot of different flavors. There's a lot of common patterns that we consider. Things such as hypotension, elevations in intracranial pressure, metabolic crisis, seizures, periodic discharges, spreading depolarizations. These things occur quite commonly. And ultimately, the underlying problem, as has been shown really, really nicely by the Cambridge group, is that you've got this very heterogeneous or patchy mismatch between the brain's supply and its demand. And so there are areas of hypoxia, separate areas of ischemia, areas that are not getting what they need to work the way they need to. And frankly, the injury creates an inability for the brain to intrinsically match supply and demand, as it normally does, kind of in the concept of neurovascular coupling. But this is your patient, and so our job is to try to intuit the secondary brain injuries in this kind of scenario. And that becomes really, really challenging, both clinically and from a research standpoint. You know, the analogy from this, and this is really an analogy that came from Michael Schmidt, who's one of the people that I trained under, is that, you know, when, again, in a patient who's got a good neurological exam, a patient who's awake or able to follow commands, for instance, you can sort of fly by sight. You can examine the patient, kind of understand, hey, they've got a problem with their motor function on the right side, or they've got a problem with this particular extraocular eye movement. But in a patient who's comatose, where they can't interact with you, suddenly you're left having to try to intuit the stuff from the numbers, so to speak, or whatever you happen to be measuring outside of that clinical exam. So that's great in concept, but the problem is, specifically when it comes to traumatic brain injury, we've never really defined that injury in terms of the numbers, the measurements, the physiology, right? And so anytime you look at clinical trials where they've really focused on one aspect of this, whether it's intracranial pressure or cerebral perfusion pressure or temperature, we end up failing to show that focusing on the physiology and correcting abnormalities in physiology actually makes a difference in terms of outcome. And part of that is that this physiology, these measurements, these things that we're trying to use to intuit the brain's pathology and how we're treating it, is not just relegated to pressure, which is the most common thing that we measure, intracranial pressure, right? It's not just relegated to autoregulatory function, or brain tissue oxygen, or metabolism, or even the ramifications of having low blood flow and function. We've never really defined TBI in terms of that, in terms of how we monitor and manage patients. And so when you look at the newest iteration of the guidelines for the management of severe TBI, there's no class 1 or 2A evidence for any physiologic measurement or threshold. Even intracranial pressure has a 2B recommendation. So, you know, really this is territory that needs to be better defined. But nonetheless, clinically, what I'll make the case for is, you know, clinically we can still make some real headway in using multimodality monitoring. This is the intracranial neuromonitoring that we use here in Cincinnati. And so we'll be referring to some of these particular modalities. Multimodality monitoring in general, though, is not specific to having all 4 of these components, for instance, or having one specific measurement or another. It's really whatever you happen to be using and trying to put that together. What we happen to use is a quad lumen bolt that's placed usually in the right or the left at the Cooper's point. And through that bolt, we place 4 different catheters. We have an intracranial pressure and PbTO2 catheter, the Rometic. We have a depth electrode, microdialysis, and Hemodex, which is a thermal diffusion probe that measures blood flow. And in order to try to interpret all this stuff, we actually put it all together in more or less one place through a data aggregation unit that you guys are familiar with there at Sinai, which is the Moberg system. And when we do this, we found that you actually get pretty good data. This was data from our first 2 years of doing this kind of in a standardized fashion. What we found was that we were able to get these probes in, get this kind of multimodality monitoring platform up and running within about 12 hours, a median of 12 hours from injury. And we monitored folks for about 4.5 days. We were able to get all of those measurements for each patient 90% of the time or more, which is great. And you know, the safety of this is pretty consistent with the existing literature. You've got about a 2 to 3% incidence of what's considered significant tract hemorrhage. In our case, it was a non-operative expanding hematoma that didn't require any further management. So this is something that's relatively safe to do. The incidence of symptomatic hemorrhage and EVD placement, for instance, is 7 or 8%. So it's within the limits of what we consider to be kind of standard, and provides pretty good data to try to help guide how we manage these folks. So I'm going to kind of start the conversation a little bit with an example, because I think this highlights sort of the complexity of what you're dealing with, but also the utility of it. So this is a young patient who was involved in a motorcycle collision. Her initial DCS was 6. She had a significant pre-hospital hypoxia from esophageal intubation. And she came to our ICU, and this is our multimodality monitoring platform. And the window you see here is about a day and a half. And the colors will be consistent throughout the talk, so I'll walk through these real quickly. But in red, you have heart rate. In orange, here's the mean arterial blood pressure. In green is the intracranial pressure, and below that, cerebral perfusion pressure, brain tissue oxygen in orange, cerebral blood flow here in purple, labeled as perfusion. the K constant, which is a marker or a measurement of brain water content, and the brain temperature. So what I want to highlight is at the very beginning of this monitoring session, and you can see this patient's CT here, she had not only the bolt here on the right, but also an EVD, significant cerebral edema and deep contusion in the left. What I want to point out is in the first 6 hours of monitoring here on the left side of the screen, you can see the heart rate's quite high, and that comes down over time, but the blood pressure is reasonably adequate. The cerebral perfusion pressure is a touch on the low side, and your intracranial pressure, which I have kind of marked with a red dashed line at 20 millimeters of mercury, is riding high, but it's not super, super high. There's some brief ICP spikes. But you'll notice in orange there's a brain tissue oxygen, and that's lower than you'd like for it to be. I've got the dashed line here at 20 millimeters of mercury, which is the sort of threshold that we tend to think about as being, lower than we'd like for it to be in this case. So in this context, the decision was made to try to bring up this CPP. And in order to bring up the cerebral perfusion pressure, we actually started a pressor here in the red arrow. And with that, you can see the blood pressure goes up a little bit, but the cerebral perfusion pressure really comes up nicely as this intracranial pressure drops. And as that trends up, you can see really nicely the brain tissue oxygen is going up too. So you've got a problem with your mechanics. When you increase flow, you've got increased distal delivery of substrate inferred by that increase in dissolved oxygen here in the interstitial brain tissue. And with the right metabolic substrate, now the brain's able to function a little bit better, but because of the brain injury, what you see here in these red X's down at the bottom is the onset of seizure activity on the depth electrode focally there in the region of the bolt. Shown here, this is the scalp EEG over that right side, and this is the depth EEG in the frontal subcortical white matter and frontal cortex on the right as well. And you can see this evolving rhythm on the depth EEG that occurs. So you've got mechanics that you've improved, metabolism that you've finally kind of provided adequate supply, and subsequently the dysfunction of the brain as a result of the injury becomes manifest. What's interesting here is you don't see this seizure activity on the scalp EEG at all. This really was just on the depth EEG. Now, with seizure activity comes an increase in metabolic demand. So now that supply you've finally gotten better is now subject to an increase in demand, and as a result, you actually have an increase in cerebral edema. So you've again gotten to a situation where supply and demand are mismatched. The brain tissue is vulnerable and begins to swell. And that K constant, a marker of brain water, suddenly increases after these seizures begin. And clinically, she develops a dilated pupil suggestive of herniation. Subsequently, her ICPs become refractory, her blood flow begins to decline, and she went on to have a poor outcome. So you can see this bidirectional, very complex relationship that is reflective of secondary brain injury, but in ways that often interact, in ways that one monitor may not give you the data that you need to intuit what's actually happening. There's a lot of challenges to being able to do this in a systematic way and to do this in a research way. Challenges in the clinical side of things, as you guys probably recognize by doing this yourselves or from even thinking about the case we just talked about, there's not any standards about what data you're supposed to use. What if we didn't use the depth electrode? What if we didn't have PbTO2? We don't have any really agreed upon contexts of use. What kind of patients actually need multimodality monitoring? There's a lot of challenges in integrating things. If you didn't have that integrated screen, for instance, would you have known that the depth EEG began to exhibit seizures only once the PbTO2 climbed above a certain threshold? Well, you may not have, right? You've got to be able to put everything together. And it's hard to access this data in real time. It's hard to be able to store or archive this data because it's big. And trying to capture the context of what's happening. Did that patient miss an anticonvulsant? Did they have a treatment for ICP that may have lowered their ICP instead of that pressor increasing their CPP? Those things aren't standard either. And interpreting this, well, I kind of did it for you in this case. We can look back and see it, but what if that's your patient? How do you interpret all that and contextualize that for your clinical team or use that to facilitate your own clinical management? And those same challenges, of course, apply to research, which is a lot of what we work on with this data on the back end. There's no standards for how you look at this data in conjunction with other centers, how you label this data, how you connect this clinical data with, or how you connect this data with other clinical data from your medical record systems, et cetera. right? So there's a lot of challenges. So we've been working on some of these challenges, and I'll spend a little bit of time talking about some of the directions that we've been headed and trying to standardize the information that you are seeing on that screen for patients exactly like that in ways that can actually help drive our management as a community. So as part of a DoD-funded effort, we've been working toward trying to identify where our current medical terminology standards fall short. And as it turns out, there's a lot of missing terms. The IEEE standards, for instance, which define the labeling for arterial blood pressure, for SpO2, things that you and I kind of take for granted as being just something that, yeah, that's what that is. That's your SpO2. There's actually no standard label or definition for brain tissue oxygen. It's kind of hard to believe, right? And there's actually a ton of these terms that are completely missing from existing standards. There's also a lot of challenges in curation, as I mentioned. So one of the objects of that same DoD-funded study, as well as my own NIH-funded work, has been trying to aggregate this from clinical trials. The observational tract TBI study has a cohort of sites that use the CNS monitor, and we've been able to gather that information, put it together, and aggregate it. And what you see here, for instance, is by center the types of data that are being gathered. And again, multimodality monitoring doesn't mean a specific set of measurements, right? And so in this case, people use different things, but what you can see is, the variability here. People tend to record the arterial blood pressure or the ECG pretty commonly. Intracranial pressure gets recorded pretty commonly, but when you start looking at brain tissue oxygen, EEG, or blood flow, the numbers drop off relatively rapidly. So we're not doing things quite exactly the same, but we have to be able to label things the same so that we're all talking about the same thing. And that's a huge problem too. So take, for example, 2 patients from that big observational study, right? This is one, and here's their multimodality monitoring. So you've got arterial blood pressure here, and this is measured at the wrist. It's level at the heart. You have an intracranial pressure monitor. It's a rhometic device. It's in the right frontal lobe. You have an EVD. Where's that at? Well, it's in the right frontal lobe. It's leveled at the tragus, and it's closed, so it's transducing continuously. You have a CPP. What's that based on? This ICP or the EVD ICP? You've got your brain tissue oxygen, which here it's labeled UVB. Why? Well, the Philips monitor that we have at our shop, where this patient came from, doesn't have a PBTO2 label. And then you have, in this case, a PRX, which is a moving average correlation coefficient of ICP and arterial blood pressure. Which ICP, right? So you have to be able to identify all these things so you can interpret this stuff. And if you look at a very similar patient from that same data set, you've got an arterial blood pressure that's being measured at the femoral artery. You've got an ICP monitor that's a different brand. It's Camino. It's on a different side of the brain. It's on the left. You have an EVD over here, and it's actually intermittently opened, as you can see here, to drain. So your transduction is intermittent. You have gaps in the data. And you have a CPP. In this case, it's being derived from the intracranial pressure measured at the EVD. And so your CPP drops out at times. You don't have a CPP at some points. The brain tissue oxygen is labeled LAP. So what is it labeled at your shop, right? These are the kind of questions that you have to think about. And then, of course, if you want to collaborate and look at this information with other centers, which is, what I think the hope is and what's needed to be able to study this stuff and to be able to understand best how to detect these secondary brain injuries, you really have to start to kind of hang the ornaments on the tree, so to speak. Find these labels and apply them in the right context, so that you can compare apples to apples. Volume's a big issue as well. So data size is huge. Our multimodality monitoring data averages somewhere between 1.5 to 2.5 gig per day. That's a big amount of data. And so if your particular hospital is able to gather this information, having a place to put it, having a place to access it can be challenging. And so we've been working toward cloud-based solutions, and this is something that we've developed in conjunction with Dick Moberg through a DoD-funded effort as well. And this is actually being used for Boost and for PreciseCap. And so this, hopefully will allow for harmonization of not just that data, but data from other studies, and thus collaboration and better definition of what these secondary brain injuries look like when you start putting all of these different pieces together for specific patients. When it comes to clinical care, it's really the lack of standards. And so how you guys may do multimodality monitoring, whether it's EEG and TCDs, or whether it's ICP and CPP and a PRX measurement, they're going to be different from what I'm doing. And so we have to have some kind of standards as to what maybe constitutes this kind of thing. And there's a lot of variability when you think about how people measure the mechanics, the metabolism, the function of the brain. Ultimately, all pieces that you have to have put together in order to make these inferences that we make. And internationally, there's a lot of variability. Of course, ICP is the most common. We all tend to do that, right? And that's because it's been around for a long time, obviously, and that's because it's got the best evidence. But when you look back at the, for instance, TQIP data, 11.5% of eligible patients undergo monitoring. Right? If you look at the Brain Trauma Foundation guidelines recommendations for using potentially ICP monitoring, and when you look at the Center TBI group, this is the kind of European version of TRACK across 60 some odd centers. There's a lot of variability, both in indications for ICP monitoring, which you can see in the bar graph here on the right. These are some of the indications that people endorse for ICP monitoring. You see the variability there. And variability in what's actually used. Again, most people down here at the bottom, most people use ICP, but EEG is used a little over half the time, TCD is used about half the time, brain tissue oxygen 1 out of every 5 patients with severe TBI are getting this modality. And so, again, there's very few standards in terms of who's getting this stuff and who are we applying to and what are we using to generate multimodal data. Again, intracranial pressure tends to be the most common. I'm going to skip over some of these things fairly quickly just to make sure we're in time. But ultimately, intracranial pressure monitoring is thought to improve survival, particularly, or mortality, particularly. But at what threshold do you start treating ICP? And what's the best way to use intracranial pressure? Ultimately, it's a biomarker of secondary brain injury, but the secondary brain injuries that can lead to increased intracranial pressure are really nonspecific, right? So looking at some of the data that's out there, there was a nice receiver operating curve that suggested that you've got probably the best association with outcome at 35 millimeters of mercury. That's a much higher threshold than we're used to treating. If you look at intracranial pressure over time, this nice paper by Giza et al. Coming from Geerfurt Mayfroyd's work in the Netherlands, suggests that your ICP thresholds are going to change over time. So you can have an intracranial pressure of 20 millimeters of mercury for 30 minutes, and that pushes you into this red zone where your odds for mortality go up by a factor of 4. But if you look at an ICP of 50 millimeters of mercury and you spend 4 hours at that threshold, you've got the same propensity for having poor outcome. And it's kind of scary because we don't treat ICPs of 15 or 16, right? But there's some spuriousness to this data, and this is part of the problem in the sense that the majority of the data tends to be down here when you look at the mutual information, the information that's contained within the intracranial pressure information relative to outcome. What you end up finding is that you lose a lot of information out here in the extremes of your ICP. So in other words, our thresholds are based on what we commonly record, not necessarily on actual physiology. It's an epidemiological phenomenon that we have these thresholds. And if you've got someone who's got an ICP above 20, we're treating that. So how do you interpret whether that's impacting outcome? Is our treatment actually that's impacting outcome? Or is it that that patient is refractory to our treatment? We've been working on trying to quantify intracranial pressure burden. This has been done, of course, before, usually in single center retrospective studies. And so doing this in the TRACK TBI cohort, what we found is that there does seem to be sort of this idea of the more ICP you have, kind of regardless of treatment, potentially the worse your outcome, certainly the lower your survival. But whether that impacts other more important things like your cognitive functioning or your functional outcome down the line is still a bit up in the air because of all of these confounders. And it's going to take a lot of data, a lot of patients to be able to intuit that. A lot of kind of editorial work recently over the last year and a half has highlighted the fact that really intracranial pressure, being a non-specific secondary brain injury marker, is in isolation probably not the right target. right? And I think we all kind of have an intuitive sense of that. There's other stuff we need to think about. We think about perfusion pressure, of course. That's really important. Why do we think about perfusion pressure? Well, the intracranial pressure is going to go up as we begin to lose some of that cerebral perfusion pressure. We move toward the lower limits of our autoregulation. And of course, the Cambridge group has really nicely over the last 2.5 decades shown that we lose this ability to autoregulate after severe brain injuries, to the point where sometimes autoregulatory function is completely lost. Of course, you guys are familiar with the idea of PRX. I'm sure this is the idea that normally we do regulate our blood flow despite changes in mean arterial or cerebral perfusion pressures. But after traumatic brain injury, severe subarachnoid hemorrhage, other diffuse brain injuries, you tend to lose that ability to regulate. So you have a positive correlation between the mean arterial pressure and the ICP, which is the definition of the PRX. And mapping that PRX along with your CPP, you can identify areas where autoregulation is still at least relatively maintained. And in aggregate, over 300 patients worth from the UK, they found that this optimum CPP, the CPP where you really seem to have the best autoregulatory function, is around 70 to 75. That's higher than the Brain Trauma Foundation guidelines recommendations for keeping a CPP of 60 to 70. So it tells you something about the fact that it's not just intracranial pressure, it's really the blood volume that's within the intracranial vault, and it's the ability for the brain to auto-regulate or regulate its input pressure and what it's doing to blood flow. And those targets may be different than the empiric targets that we're used to seeing, again, from the epidemiological literature. So we really have to use ICP in context with, for instance, in this case, other mechanics, flow, pressure, and autoregulatory function. This is important, right? And it's been shown that the further away you are from that optimum CPP, the higher your mortality. And of course, this is being studied now in larger studies out in Europe. We've kind of done the same, or replicated that same idea in our own clinical work using an open source graphical user interface to be able to calculate this stuff in our real-time data. And that's the idea of ICM Plus is another software that's made by the group that defined PRX. And so these are kinds of things that, applying this to your intracranial pressure monitoring can really give you a better view of the mechanics of what's going on after brain injury. Cerebral blood flow directly is also helpful, but maybe not the absolute value of blood flow. And that's been a real big challenge when you think about how to monitor the brain, because especially after traumatic brain injury, cerebral blood flow changes dynamically. There's this classically described three stages of blood flow changes after a severe traumatic brain injury, or other severe injury for that matter. The first stage is hypoperfusion. So the brain gets injured and it undergoes a period where the CMRO2 is relatively low and the blood flow goes with it. It's also relatively low. Then there's a period of hyperperfusion that lasts for a couple of days. And then the third period is actually called vasospasm. It's not necessarily the same thing as what we think about with subarachnoid hemorrhage, although it can be in 20 to 25% of patients. But it's referred to as vasospasm because you have this gradual decrease in blood flow back toward probably more normal levels. And this is actually shown in some really nice time series PET data from the Cambridge group, as well as our own data, which has suggested very similar trends. But when you talk about ischemia, and that post-zero or post-trauma day zero hypoperfusion we're talking about is not the same thing as ischemia. Low blood flow after traumatic brain injury really is defined by how it's matched to metabolism. And true ischemia, which is defined as an increasing oxygen extraction fraction, actually doesn't occur as frequently as we think. So your traumatic brain injury patients are not having widespread ischemia when their CPP is 50 necessarily, if they're really sedated, for instance. In fact, ischemia only encompasses 2 to 6% of the total brain volume after traumatic brain injury. So there must be something else, right? So we actually took a look at our blood flow data. And again, we found sort of that same hypoperfusion, hyperperfusion, vasospasm sort of trend, which you can see here. But the absolute blood flow didn't seem to correlate with how patients did. So it didn't seem to correlate with what you would expect for instance, ischemic burden to correlate with. What was interesting is that we found that the complexity of the blood flow was actually way more important. So we looked at our blood flow signals over time and looked at the frequency content and looked at complexity. And what you can see is that there's this a sort of disrupted complex blood flow regulation that occurs in normal brain, as you would expect for people who have autoregulation, who have intact neurovascular coupling, right? Blood flow is tightly regulated, and it's going to be highly variable in healthy, normal brain. That's what the brain does. It desynchronizes. And so when you see synchrony, think seizures, right? When you see synchrony in the brain, it's abnormal. The same goes for our mechanics. When you see synchrony in our blood flow signal, that tended to correlate with poor outcome. And actually was one of the strongest predictors of poor outcome of the different variables that we've measured from cerebral blood flow, and did better at predicting outcome than standard clinical variables alone. So this becomes really important because we have to kind of think not only about what we're measuring, but also how we're using that measurement. Is it just a mean blood flow that we need to look at? Is it a mean ICP that we need to look at? You have to look at those values, those measurements that we're making in context, and perhaps even using different methods. Linking the mechanisms and the metabolism of the brain is really the function of the brain. And we talked about the fact that our clinical exam tends to be limited in these folks. And so EEG ends up being an extension of the clinical exam that really provides that window into how the tissue is functioning, which ultimately is what you're trying to infer in doing multimodality monitoring in order to guide your management. You can do this really there's kind of two ways that are in the literature that have been used in patients with traumatic brain injury and subarachnoid hemorrhage and other severe brain injuries. One is using a subdural strip electrode. This tends to be a 6-contact platinum electrode strip that kind of lies on a soft silicone surface, and it's placed directly over the brain operatively, usually in patients who have undergone craniotomy or craniectomy. And your ideal placement is that you've got a lead that's near the injury in the penumbra of the injury, and then extending along, ideally, a contiguous length of cortex out away from that injury. So you get sort of a geographic view of the function of that tissue in response to the injury. Is this safe to do? I mean, obviously we do it in patients with epilepsy, right? They hang out in the EMU with their 64 lead grid. And in fact, in brain injury patients, it's also relatively safe. In a series of patients with subarachnoid hemorrhage, there really were no differences in infections or bleeding. In the Spreading Depolarizations 1 study led by Dr. Jet Hardings, it was also very similarly minimal complications. And the strip is removed at bedside, of course, and that can rarely create problems in terms of retained leads. But again, this occurs in less than 1%. When you talk about patients with epilepsy surgery, complications are significantly more common, and we consider those to be, acceptable. And so I think for brain injury, placing strips is not only safe, but also reasonably more safe even than the larger electrode arrays that we use in epilepsy patients. But many of our patients don't have craniotomies or craniectomies, as you can imagine. And so the other option is to place a depth electrode, which is a small catheter. It's got 6 to 8 contacts inserted through usually a bolt, or it can be tunneled, but this pierces through the cortex. And overall, it's about 2 centimeters in length. The cerebral cortex is about 0.5 centimeter. So you get a couple of these electrodes passing through cortex, allowing you to measure at that location, a single point, the electrical potentials. What's nice about this is it really does link those mechanics and the metabolism that we've been talking about. So at its simplest form, function requires flow. You guys are all familiar with this concept. The lower your blood flow, the slower your EEG becomes in sort of this linear fashion. And while I mentioned that absolute blood flow itself may not be as critically important because of the changes that occur after a severe injury, we definitely see this, and it has some clinical implications. So I'll give you an example. This is a 57-year-old guy who was involved in a traumatic brain injury, and it's post-trauma day 3, and he starts to get these giant plateau waves. As you can see here, it starts with stimulation, and then it leads to this kind of sustained plateau in intracranial pressure. And below is our blood flow. This is absolute blood flow, and you can see what this is doing to his blood flow. It really is reducing it pretty substantially. And while this could be because he got a big bolus of sedation here, it is fairly low and seems to be right along with this increase in intracranial pressure. So we need more information, though, to know whether this is truly something where the pressure is preventing the blood flow and creating injury, or whether this is something else. And so that's where the EEG becomes important. And you can see in the scalp EEG as well as the depth EEG, there's actually a decrease in the faster frequency activity, just as you would expect from a drop in blood flow, that occurs simultaneously. And these probes, the depth electrode, the blood flow monitor, the ICP monitor, they're all located in the same spot. So you can kind of intuit what's happening at that tissue level. Looking at the raw EEG, you don't have to take my word for the quantitative stuff. You can see the dropout in faster frequency activity, right? So that's a patient where you might go, okay, I'm seeing this effect. Maybe we need to limit our exams. Maybe this is someone who needs some wiggle room in their compliance curve. This is someone who you might treat with a hyperosmotic therapy, even though their ICP tends to be a little bit on the lower side, because when they get stimulated, they can't tolerate those changes in blood volume, right? And so you can modify or precisely manage that patient by knowing these kind of relationships. Now, of course, seizures tend to be important as well. And a lot of this data you guys are probably familiar with regard to scalp EEG or continuous EEG monitoring. And what's important is that, using continuous EEG monitoring, seizures are pretty common. Depends on the study. We did a study that suggested they were actually fairly infrequent, but somewhere between 3 and 22% patients with traumatic brain injury specifically do have seizures. And what's interesting about that is these seizures are associated with injury severity, but they can also create secondary brain injuries. We saw that in the example at the very beginning. There's literature from UCLA, Paul Vespa's group, that suggests that they can increase intracranial pressure, create metabolic crisis. They lead to hippocampal atrophy. And using a retrospective analysis of a prospective randomized controlled trial, we actually found that these seizures impact cognition. So they have these longer term impacts on not just functional outcome, perhaps, but on things like your cognitive function, which makes sense. These are affecting cortex, right? And so that's really important. And that's been shown in other disease processes too, such as subarachnoid hemorrhage. So detecting seizures in order to treat them can prevent the secondary brain injuries that may not lead to someone having a lower GOS score, but certainly might lead to having worsened cognition. And that's a big impact on patients' lives. Work from Columbia and from UCLA both have suggested that seizures, even when they're small enough to only be detected using a depth electrode, create significant impact. Now, when you look under the hood, so to speak, go past the scalp EEG and actually look at the cortex, seizures are more common. They occur in about 50%. But even those seizures that are undetectable by scalp, and that's 40 to 50% of them, create systemic changes in physiology, such as increases in heart rate and blood pressure, and create changes in your metabolic supply and demand matching. So the faster the seizure discharge, for instance, the lower your brain tissue oxygen, presumably because you've increased the oxygen extraction fraction of the tissue, which is now sucking in that dissolved interstitial oxygen, creating also increases in the lactate pyruvate ratio, suggestive of metabolic crisis. More common than seizures even, though, are something called spreading depressions or spreading depolarizations. And these are phenomena that have been described for a long time and are actually quite common. They were first described as spreading depressions because when you injure the cortex itself stops generating the nice, normal, fast frequencies of an EEG, and it flattens out or depresses. And what was interesting is in the first descriptions of this phenomenon, that area of cortex that became depressed was then kind of moved down the cortex to the next area at a speed of about 3 millimeters per minute, and that area became depressed. And so you see the spread of this depression of the high frequency activity. Well, what causes this? The actual phenomenon is a depolarization of the tissue. And so there's a 1 to 2 minute DC shift or depolarization of a large mass of gray matter, and that spreads throughout contiguous gray matter. Depolarization of tissue means that your resting membrane gradient goes to 0. And when you do that, you have a complete shift of your ion gradients, driving water into the cells, creating cerebral edema, and inhibiting the cell from having normal action potentials, generating normal postsynaptic potentials, which are the things that you're recording on your EEG. Hence the depression of EEG activity. Now, if you don't have EEG activity because your brain's already so injured, you still can depolarize because injured tissue still has a membrane gradient. And when you do this, when you depolarize, it's kind of like when your AA batteries run out of battery, right? When they run out of charge, you have to recharge them, right? So you have all these chargers at your home, I'm sure, where you have your chargeable batteries, and you have to plug these things in. It takes like 8 hours, right, to charge up your AA batteries. It's incredibly energy intensive. When your brain tissue depolarizes, no differently, it's incredibly energy expensive. You have an increase in your CMRO2 of something of like 200%, lasting hours. You have a drop in your ATP of about 50%. You have an increase in your CMRO2 as well as your CMR glucose. The tissue itself becomes metabolically very active in an attempt to try to restore those membrane gradients. You can see here microdialysis data suggesting that brain tissue that depolarizes loses glutamate or spills glutamate into the interstitium. There's an increase in lactate and pyruvate. And what's really scary is when the brain tissue can no longer repolarize, can no longer regenerate those membrane gradients, you end up with a sustained depression as the tissue begins to start its death clock, right? So the tissue depolarizes, and this starts a clock toward which the tissue begins to die. In traumatic brain injury, this is really common. And so about 60% of patients with severe surgical TBI exhibit these. And when you have these clusters of depolarizations that lead to electrical silence, this actually impairs your motor recovery and leads to an unfavorable outcome. Here's an example of what we're talking about in real life. This is a patient who had a depth EEG placed. And what you can see here in red is a 1 to 2 minute depolarization or depolarizing shift in the DC signal of the EEG and a depression or flattening of the high frequency activity. What's really important about both of these phenomena, seizures and spreading depolarizations, is that they reflect tissue at risk. And this is a really key component. And I'm going to end in just one moment and hopefully kind of wrap this or loop this back around. But both seizures and spreading depolarizations co-occur, and they both result from and they both mediate metabolic vulnerability. So that supply and demand mismatch that leads to ischemia, that leads to hypoxia, results in dysfunction in your normal metabolic structures such as mitochondria. This has been shown in some really, really nice modeling. Ultimately, the longer you're depolarized, the more likely you are to progress to death of the tissue. So one last example to end on of this occurring and how this is important to monitor for as well in the context of everything else. This is a guy with a severe TBI, as you can see, 76, had a fall, biformal contusions, developed a neuroworsening event, and in that context had a bolt placed with a depth EEG. Here's 6 hours of EEG recording. You can see these depolarizations occurring, depressing the fast frequency activity that initially was present and able to show back up as the neurons or as the cortex repolarized, but over time, these gradually peter out. And the brain tissue becomes exquisitely vulnerable as it's no longer able to restore its membrane gradients. Those neurons begin to experience that vulnerability and seize as a result. So seizures then develop as the spreading depolarizations go away, requiring us to have to switch and focus on the seizures, which we finally got under control. But after 3 days of battling these things, the family opted to withdraw care, and he had poor outcome. So to sum up, multimodality monitoring is really aimed at detecting not just secondary brain injuries, but the mismatch between supply and demand, that bidirectional change that occurs when you have these common secondary brain injury patterns. There's a lot of challenges to doing this, both clinically and in the research environment, but it is something that can be done. And while we improve our ability to integrate, improve the field of neuromonitoring, this is stuff that you guys can already apply at bedside, allowing you to more precisely target your patient's management after traumatic brain injury. So with that, I'm going to end, and I'll pull up the chat box if you want, or if you guys have any questions, feel free to ask. I do see one question in here. I'll go ahead and answer live, which is from Dr. Shutter. She said, can you comment on the reliability of CBF monitoring at your center, and how do you deal with the temperature's impact on Hemodex data? And that's a great question. So the cerebral blood flow monitor that we use is the Bowman Perfusion monitor. It's a thermal diffusion probe that's based on creating a stable thermal field and measuring the diffusion of heat within that field. We found that the cerebral blood flow signal was reliable. More than 50% of the time, we got reasonable numbers that you could trend more than 80% of the time. The probe itself does have gaps as a result of a built-in recalibration that occurs every 30 minutes to 2 hours. And that's designed to reestablish the thermal field. So you end up with these signals that kind of have a gap to allow for recalibration. And the more frequently you do that, the better the signal. But the gaps can be difficult because things happen during the 5 or 6 minutes that you recalibrate. So reasonably reliably, we were able to get this, 60% of the time, 50 to 60% of the time when we got good blood flow, we could trend, was certainly better than doing a CTA every couple of days. The temperature's impact, though, ends up being a different story. And right now we're actually trying to explore what the kind of slope of the temperature change is doing to the blood flow signal itself during contiguous epochs of CBF. But in general, it's been actually pretty useful. What I found is that, though, the absolute value, you have to interpret with everything else. And that's been the challenge, is knowing what to do with it. And it's required a lot of thought about, okay, well, if the blood flow looks like this, what else is happening with our substrate delivery, with our metabolic demand, what else is happening clinically? That tends to be the only way to interpret it. Otherwise, it gets very limited because there's not a lot of data about how to interpret it otherwise. Hopefully that answers the question. CBF is really complex. I've spent a lot of time working on it as a result.
Thanks, Brandon. It was an excellent talk. There's actually 2 questions that both kind of relate to MAP augmentation and CPP augmentation. So one from Carolina Maciel and the other one from Dr. Shutter. But basically, in particular in that case at the beginning with the 15-year-old, do you routinely take into consideration autoregulation status prior to CPP augmentation trials? And is there a fear of precipitating an ICP crisis or that kind of, cyclic spiral feedback loop in poorly autoregulated patients when you're driving the map up? And what have you encountered that in your practice? And kind of a similar question from Dr. Shutter on the challenges of using MAP to assess the impact of PbTO2 in order to help determine optimal CPP.
Yeah, those are really good questions. We do, anytime that we're doing an increase in MAP for ICP, for instance, we always look for a response invariably. I will say for most patients, autoregulation is intact enough to where increasing the CPP doesn't seem to push the ICP up, although there's obviously the subset with very severe injuries and a subset that evolve into a period of time where they are pressure passive. And so if we're doing a MAP challenge and seeing that ICP go up, we usually pull back. So part of the challenge is being sort of scientific about it. And really with all of these kind of multimodality monitoring ideas, it all is predicated on being provocative, on seeing something, making a hypothesis, doing something and seeing if it's working the way you expect it to or not. So it ends up being built in. We also use PRX, and we'll also kind of intuit things based on an optimum CPP, but often it's just clinical gestalt. The same applies to PbTO2. If we're seeing the MAP go up and the PbTO2 is going up with it, I'll often comment on the fact that the PbTO2 is pressure dependent. And I sort of separate it from the pressure dependency of the intracranial pressure in some ways. They're usually linked or are relatively similar. But I will use the PbTO2 response to a MAP challenge to set an optimum CPP at times, especially if the ICP is not very variable, such as after a decompressive hemicraniectomy.
Great. Anybody have any other questions? I don't see anything up.
No, Brandon,
that was the last one.
took us through the challenges in performing multimodality monitoring. In theory, it sounds like such an elegant way of really deploying precision medicine at the bedside, but you really highlighted what the various challenges are, right from the language we speak to how we're labeling the same things that we're trying to measure, to try to harmonize all of this data, and the biggest challenge of using this in real time, the ability to really collect this data in a meaningful manner and to use it for patient care. That's hopefully it's people like you who are going to solve this all for us, and we'll all be able to use this in a meaningful manner for improving patient outcomes for patients across the world. So thank you so much for joining us.
I can only hope. Thank you so much. I really appreciate the opportunity, guys. I see one other question. I'll type the answer, but I'll let you guys go otherwise. Thank you all so much.
Thank you. Thanks.